Assalamualaikum, I am Deba and you are watching your own channel Audiovisual Books. Ethical rationing is our today's opinion in Daily Dawn. It's 12th July 2020. The article is by Muhammad Akbar Beg. Let's start. The COVID 19 pandemic continues to spread unapologetically, creating acute shortages of essential healthcare resources ranging from simple hand sanitizers and face masks to hospital beds and mechanical ventilators. Presently, exhausted healthcare systems globally are facing the very real prospect of rationing medical goods and service diligently. It is expected that in the face of healthcare crises such as disasters and pandemics, there will be a shortage of resources which may contribute to worsening patient morbidity and mortality. Such a risk multiplies for patients suffering from breathing complaints and possible requiring ventilators. There is a very narrow window when those lives can be saved. Hence, all other medical shortages aside, the decision to initiate or withdraw mechanical ventilations is true a matter of life and death, which hangs heavy on the decision making whether they be family or the treating medical team. The goal of ventilator rationing in a pandemic is to save the greatest number of lives. Therefore, the decision about which life to save is usually determined by the likelihood of a particular patient's survival. Today, the withdrawal of ventilatory support often happens in the emergency department or intensive care unit upon the request of the patient's family and is considered to be the ethical legal obligation. Withdrawing life support without informed consent is rarely justified, but typically it only occurs in specific circumstances when further treatment is deemed futile. However, during the present pandemic, it is the acute shortage of medical clinical resources that is the driving force and guiding principle behind triaging the allocation of ventilators. The emotional trauma caused to the frontline emergency or inpatient ICU teams in making such decisions as to place patients on ventilators or withdraw them from the equipment cannot be ignored. However, a more palatable scenario may arise in leaving the decisions and the decision in the hands of a hospital ventilator rationing committee consists of relevant experts, including those with sound knowledge of medical ethics. Such a process shall serve as a buffer from critical decision making or other clinicians who may then remain focused on providing the best clinical care possible. Ventilator use should be discussed as a time limited therapy. We believe that ventilators should not be allocated based on considerations that are difficult to morally and ethically justify. Hence, parameters such as gender, caste, religion, wealth, citizenship, social status, profession, connections, and others, either individually or collectively, should not be used for the rationing of ventilators in these difficult times. The age of the patient presents an interesting conundrum, with many people simply assuming that all children would automatically be able to access a ventilator if and when required. But during pandemic times, with limited machines, moral intuition may best support prioritizing a patient, irrespective of age, who could optimally recover from treatment and otherwise would stand to lose significant years of life compared to one with chronic illness that would likely result in death within the span of a few years. There is a strong precedent for using this criterion who allocating scarce medical resources. The treating clinicians, on the other hand, should be allowed to repeal the ventilator rationing committees triaging decisions if they feel it is unjustified or unwarranted. Ventilator use should be discussed with the family as a time limited therapy and not as unlimited promise in order to set realistic physician family expectations. The duration for the trial of ventilation should not be too long, whilst causing a steady, progressive, and inevitable clinical deterioration of a patient, nor too brief in order to avoid the rapid withdrawal of ventilators from patients who, if treated for a few more days, could have survived. However, the aforementioned recommendations on how to allocate scarce critical care resources during a pandemic or disaster contain ethical and problematic provisions that require appropriate definitions and the establishment of policies on a governmental scale for uniformity during applications in various hospitals. In this pandemic, physicians may have to face situations they have never experienced before and may have to take decisions they have never taken before. This is not the time to blame the healthcare system for its inefficiencies. Our hope is that we are able to identify patients that may benefit the greatest from scarce critical care resources, ventilators per se, while continuing to remember our obligations to care for all patients mm, as best as we can under such difficult circumstances. The writers are emergency physicians at the Aga Khan University Hospital in Karachi, published on July 12, 2020. Thank you for listening.